Hello again. The next topic I'm going to talk about is acid reflux. Most people think of this as heartburn. So, acid reflux or heartburn is also termed GERD, which means gastroesophageal reflux disease. So, this is an area in gastroenterology that's very developed. And as it turns out, people do not understand this very well. Many people think that their stomach is making too much acid, but it's not that. It's just that the acid is in the wrong place. So your acid is supposed to be kept in the stomach and not in the esophagus. But the exposure of the esophagus to acid and the amount of time that it's exposed define acid reflux disease and can be quantified and looked at with what is known as a pH probe study. There's a lot of misinformation about acid reflux and heartburn in the lay population. A lot of people think it's just benign, it's nothing to worry about, it's just heartburn, and they just take antacids for it. The trouble is that you can't always rely on symptoms to be sure what the status of your acid reflux is. In order to make a diagnosis of acid reflux disease, upper endoscopy is really, I think, the best test. There are other tests that are available. pH probe is one test that's available that usually requires an upper endoscopy, however, in order to place the probe device, but not always. They are working on other ways of looking at the esophagus, such as what's known as a smart pill. In other words, a pill that you can swallow that will take pictures of the esophagus. Of course, any kind of pill that you swallow, you can't stop it and look around more if you see anything that you would like to look at further. It's just going to go down through the GI tract. And after a period of time, the battery will run out and the information then will stop coming to a receiver that the patient usually carries on their body for the information. Now I'm going to talk a little bit about some of the complications of acid reflux. You can have acid reflux with acid causing erosions in the esophagus. So erosions are not ulcers. Ulcers mean that you can see perceptible depth. Without perceptible depth, and you see streaking coming out the esophagus that look like erosive disease, that's without perceptible depth, that is esophageal erosions, and they're graded according to how many erosions and how much involvement of the esophagus is there. Anything that has perceptible depth in the esophagus is known as esophageal ulcer, and those generally are a bit on the unusual side and require biopsy to rule out cancer, which can be done through the endoscope. So esophageal erosive disease, you can have scarring in the bottom of the esophagus, known as peptic stricture. This can impede the passage of typically food, so liquids go down okay, but food may get stuck or hang up. So esophageal strictures, that implies complication of acid reflux disease and requires treatment to control and sometimes dilation. In fact, usually dilation is done as part of the evaluation to try and avoid any kind of blockage in the esophagus. One of the other complications that can occur is known as Barrett's esophagus. And that's where you have a lining change in the bottom of the esophagus that looks like the stomach lining, but is really in the esophagus. And there is increased risk of cancer developing in that lining change. It is not a big risk. It's probably 10% or less, or maybe even much less than 10%, but It depends on how much of the lining of the esophagus has changed, the lining of the stomach. Um, so if you have that lining change, it needs to be recognized and biopsied and followed, and also treat the patient for acid reflux. So all of those things are important. Certainly there are other complications that can occur with acid reflux, but those are the main ones that I've seen and the usual ones that you encounter. Now in terms of acid reflux treatment, we'll move on to that. One can simply take some antacids as needed if you have minor acid reflux problems. But if you have daily acid reflux or more frequent problems, usually medication is required. Drugs like Pepcid or Zantac, that type of medication, typically is not as strong as drugs like Prilosec or Nexium, Prevacid, those types. So the first type, Zantac, Pepcid, are known as H2 blockers, and they do lower the amount of acid production in the stomach. They don't really correct the problem with reflux coming back up the esophagus, but they lower the amount of acid that's coming up. Unfortunately, with those drugs, commonly that's where you get what's called tachyphylaxis, meaning that the drug seems to work pretty well for 2 or 3 days and then quits working so well. Now, that's not true of all patients. I mean, they may still get some benefit, but it's not as effective as what's known as PPI therapy, which is proton pump inhibitor therapy. Those drugs are Prilosec, Prevacid, Nexium, those types of medication. And there's not thought to be any tachyphylaxis with those. They do lower the amount of acid production of the stomach. They do not prevent stomach contents from coming up the esophagus. Some patients may require more than one dose a day or one capsule a day. The strategy from our standpoint is to try to keep that dose as low as possible to control the problem. There is a newer drug that is out there called Voquenza or Vonoprazan. This drug, I really haven't used it, but is thought to be more potent than even the PPIs. And generally, right now, is reserved for patients who you cannot control with PPI therapy. There has been some concern in the past that the PPI drug therapy can cause various problems. Dementia was mentioned, heart disease, a number of things have come up, but they have been basically put to rest, although there is some risk of pneumonia in hospitalized patients, and because the acid in the stomach is decreased, it may be more susceptible to certain types of infection, although generally has not been shown to be much of an issue. There used to be concern about B12 deficiency and low magnesium levels. This may occur in some patients, but typically it's not very often that it occurs, and there's no guidelines to check magnesium levels or B12 levels while you're on the medication. If you're having daily acid reflux, it's a good idea to have upper endoscopy accomplished to check for Barrett's esophagus. Make sure that everything is going okay in your esophagus. This can commonly be done at the time of colon cancer screening. If you're going to have a colonoscopy, an upper endoscopy can also be done at the same time. Sometimes this is not done because the upper endoscopy is reimbursed at half the price, and this is a deterrent for some practices, but certainly in our practice, we went ahead, any patient that needed upper endoscopy at the time of colonoscopy, we went ahead and did it, and it didn't take very long, and there was no extra problems with that in general. There have been other procedures for acid reflux. So certainly the usual acid reflux surgical procedure is known as a wrap, where they take the upper part of the stomach and wrap the lower part of the esophagus to try and obtain a better barrier between the stomach and the esophagus, so there won't be so much acid reflux there. And this can be helpful in some patients, although there's some questions about just how durable, how long this procedure would be helpful. There's an attempt to go ahead and mimic this procedure endoscopically. That's known as a TIF procedure, transesophageal fundoplication, incisionless fundoplication. There's also a LINX system, LINX, which has to do with magnets to try, both of these are trying to create a better barrier between the stomach and the esophagus to try and prevent acid reflux. I think I would not undergo those procedures yet. They're still haven't been doing those for long enough, in my opinion, to know what the long-term risks are. And a lot of these types of procedures have kind of come and gone through the years, but the esophageal wrap, or the fundoplication, it's called surgical fundoplication, which is usually done laparoscopically, has stuck around. So if the medications aren't working, you may need to have surgery done, although typically if you're on medication, it usually controls the problem. It's important to remember to take the PPI therapy, such as Prilosec and Nexium, about 30 minutes up to 1 hour before your first meal of the day. If you're taking a second dose, 30 minutes up to 1 hour before the supper is ideal in terms of how this medication works. Also, there are other instructions, such as elevate the head of your bed 4 to 6 inches. There are bed blocks you can use for that. Don't eat for 3 to 4 hours before you lie down. Don't drink a lot of carbonated beverages or caffeine. Don't overeat. Don't wear tight abdominal binding type of clothing. So there's a number of things like that that can be helpful to the patient. And I think I'll conclude the acid reflux talk here. Certainly in the book that I put together, there's a lot more information about that, all of those types of issues. Thank you.